Hello everyone, hope you are doing well. This is Teja from Naiper Mohali. I am pursuing a master degree in pharmacology and toxicology at Naiper Mohali. Today in this video, we are going to discuss distribution, volume of distribution. What does it mean? What does it mean by distribution? What exactly protein binding? All we are going to discuss in this video. Let's get started. So, what is distribution? Distribution it is the process by which drug passes from the bloodstream to body tissues. What exactly it means? It means whenever drug reaches to the systemic circulation and it has to reach tissues, that is what we call distribution. From systemic circulation to tissues, this is called distribution. So what exactly it depends upon, like the distribution depends on drug chemistry, whether the structure of the molecule, it depends on the structure of the molecule, and protein binding, and capillary endothelium, whether it is like continuous capillary or fenestrated capillary or discontinuous capillary. It all depends upon distribution, also depends upon capillary, the type of capillary endothelium is, and rate of blood flow. And it also depends upon rate of, for example, different organs get blood flow differently. The rate of blood flow to the different organs, it depends upon different things. So distribution depends upon all these four factors. So next, for example, drug can be non-ionized or ionized, or else it can be ionized at a simultaneously. What exactly determines the degree of ionization? As we discussed in the previous video, pK of your drug and pH of the medium, it determines the degree of ionization. What if pH of a medium and pK of a drug are both are same? It means that pK is equal to 7.4 and pH is also called 7.4. What if pH and pK both are equal? Then 50% will be non-ionized and 50% will be ionized. So why does alpha-fentanyl have a faster onset than fentanyl? Because just apply this concept to this, because pK of alpha-fentanyl is very close to the blood pH 7.4. So both are having same pK and pH would be same, then it will be 50% will be ionized and 50% will be non-ionized. That's why alpha-fentanyl having faster onset of action than fentanyl. Now, why I'm discussing about blood? Because drug has to travel in blood. We have to know what are the important characteristics of blood. Your blood consists of, my blood or everyone's blood consists of plasma and cells. Plasma, most 90% of water and proteins. These proteins are the important. Plasma, 55% of plasma and 45% of the cells. We should discuss about the nature of blood. It is aqueous. Why should we discuss the nature of blood? Because drug has to travel in which medium, which aqueous, like which medium? It is aqueous medium. It is not lipid medium or lipophilic medium. It is aqueous medium. And these proteins, what are the proteins involved in blood that carries the drug? We should know. So let's discuss. For example, plasma proteins. These are the plasma proteins: albumin, globulin, apoprotein, glycoprotein. It is These are the plasma proteins to which drugs can bind and they travel. Why should a drug bind to plasma protein? What factors affect the plasma proteins? What is the role of plasma protein binding? Everything we will discuss in this video. Just give me a moment. So globulins are alpha globulin, beta globulin, gamma globulin. In alpha globulin, alpha antitrypsin, angiotensin will be there. Beta globulin, coagulation factors, transferrin. This comes under in beta globulin. Gamma globulins are nothing but antibodies. Antibody A, G, A, M, E, D. These are all are antibodies which comes under globulin. So plasma. We should know what exactly plasma is. What aqueous, 90% of water will be there in plasma. And also the important thing is that plasma proteins, albumin and globulin. Why I'm just um, telling you albumin, globulin? Just give me a moment, I will discuss you what exactly albumin plays a role in distributing a drug. For example, take a drug. It has to distribute. For example, it is a lipid soluble drug which is non-ionized. It needs plasma protein bind. Why a drug needs a plasma protein? Because the medium has been seen that plasma, which is aqueous in nature, but the drug is lipid in nature. In order to carry lipophilic drug in aqueous medium, it needs a plasma protein. So what are the plasma proteins? As we discussed, that albumin is a plasma protein, globulin is a plasma protein. These plasma proteins carries the drug. For example, this is lipid soluble drug which is having acidic drug. This is acidic drug. So which plasma protein is going to carry the drug? Obviously albumin. Albumin carries acidic drug. Basic drugs can be carried by alpha 1 glycoprotein. Okay, sir, what if a drug is water soluble, that is ionized? So there is no need of binding to plasma protein. Why? Since plasma is our blood is aqueous, there is no need to carry a drug with a plasma protein. So, and also one of the important factor is that only free is the active, which uh, if a drug is bound to the plasma protein, it is inactive. Bounded drug is inactive, unbounded or free drug will be the active. See, plasma proteins are abundant. Plasma protein binds more greater than drug concentration. Anytime a drug want to bind a plasma protein, it will be available. It is not saturated because liver produces plasma protein in in a more like there will be plenty of plasma proteins will be there in the blood itself. It won't be saturated. Free unbounded portion of the drug usually constant, whether it is a low dose or high dose. So um, drugs drugs also compete each other for their plasma protein binding. As we can see, Rana and Bahubali, in Bahubali 1, they are both are competing for binding, like both are competing each other to sit in this throne. Like this is like these drugs are also compete each other for binding to albumin. For example, like they compete each other for binding to albumin. For example, this X drug is binding to albumin. This B drug can displace the drug A if it is having more affinity towards albumin. The displaced drug, the free fraction of the displaced drug, it will be more, and it also causes toxicity, or the free bound drug may give rise to toxicity. For example, consider this is sulfonamide. For example, consider this drug as a bilirubin and this drug as a sulfonamide. As bilirubin binds to albumin and it is displaced by sulfonamide. So bilirubin concentration would be more in the plasma protein which is not binding to plasma. Then free fraction of displaced bilirubin increases and it is causes toxicity in children. It causes canerectus which is dangerous in children, in child. So in this slide, what I want to tell is drugs, drugs also compete each other for binding to plasma protein. So in next we'll go to next slide. For example, now let's talk about protein binding. as been seen in previous video, albumin and alpha acid glycoprotein, these are the these are the plasma proteins. Albumin that binds to albumin which is basic plasma protein, and alpha acid glycoprotein, this is acidic plasma protein. Since albumin is a basic, it obviously binds to acidic drug. So, sir, what are the acidic drugs that are available? For example, phenytoin. If you take in if you consider anti-epileptics, phenytoin, phenobarbital, valproic acid, these all are acidic drugs. NSAIDs like aspirin, paracetamol, in antimicrobials, sulfonamide, tetracycline, penicillins, warfarin, tolbutamide, these all are acidic drugs. So it obviously uh, bind to albumin, which is basic plasma protein, whereas anti-arrhythmia like alpha acidic protein is acidic protein. Obviously the basic drugs, anti-arrhythmetics, beta blockers, calcium channels, opioids, imiprim, all these are binds to alpha acid glycoprotein. So what is the importance of plasma protein binding here? The plasma protein important of plasma protein binding is like for example, if you see in nephrotic syndrome, in which loss of albumin will be there. When there is loss of albumin, the drug won't bind to plasma protein, thereby increasing concentration of drug in plasma. Then it causes toxicity, because most of the drug will be unbound, which is free, which is bound to tissue, and it causes toxicity. In cirrhosis also, there will be like in a liver failure condition. In cirrhosis, there is decreasing of albumin and alpha acid glycoprotein, which is synthesized by liver. Since a patient is in cirrhosis condition, there will be no albumin and no low secretions of albumin, low production of albumin, low production of alpha acid glycoprotein. Then there will be toxicity of all drugs, because since it is not binding to the plasma protein, and most of the drugs will be free, and it causes free fraction of the drug causes toxicity. So in inflammation condition also, in inflammation condition, more acid, alpha acid glycoprotein it produces in acute phase, and most of the drug will bind to plasma protein. Then there will be decreasing in the volume of distribution. So and one more importance is plasma protein binding, and it is non-specific. Like in consider plasma protein like albumin, multiple drugs can bind at the same site, and there will be displacement reaction, which we discussed previously. Displacement, um, sulfonamide is displaced by bilirubin. All this causes displacement. It also causes toxicity. So plasma proteins, what we discussed in this slide, plasma proteins are albumin, alpha glycoprotein, lipoproteins, and type of the drugs it will binds. Like acidic drug will bind to albumin, basic drugs alpha acid glycoprotein, lipophilic drugs lipoprotein. So this is the displacement reaction. For example, aspirin is there, and tolbutamide. Tolbutamide binds to albumin. When you given two drugs, like drug interaction, for example, aspirin displaces the tolbutamide, then tolbutamide concentration would be increases in the plasma. So when tolbutamide concentration would be has been increasing, then there will be release of insulin. It causes hypoglycemic. And second important displacement reaction is phenobarbital, increases the phenytoin concentration, like this. And as we discussed, like sulfonamide is contraindicated in neonates, because it causes kernicterus, as we discussed earlier. We can see that sulfonamides is binding to albumin, and uh, like bilirubin, it is like toxic, as we discussed in previous slide. And it is also dangerous. Not like blood brain barrier is not fully developed in neonates. When enters, it just enters into CNS, and it is causes neuronal damage. Like bilirubin can cross, like in neonates it is not, blood brain barrier is not fully developed, and it crosses and it causes neuronal damage. And aspirin, we have seen that displaces methotrexate, indomethacin, phenytoin displaces warfarin. These are the important displacement reaction. For sure it will be asked in 2024 GPAD, in GPAD examination. So there are the two barriers to distribution. One is blood brain barrier and another one is placental barrier. What is blood brain barrier, what exactly it is, what inhibits them, we'll discuss. Membrane is a lipid bilayer that prevents uh, passage of water soluble drugs. Like blood brain barrier, it prevents the water soluble drug to enter, and membrane is also lipid. And if the drug is lipid soluble, it can easily cross the membrane. So lipid soluble drugs can be easily cross the membrane. Important note that in inflammation, blood brain barrier will be disrupted. So that, so in for example, in inflammation, for example, consider meningitis, in which blood brain barrier will be disrupted. So if you give any drug, like any antimicrobial drug, it can easily, for example penicillin or cephalosporin, it can easily cross the blood brain barrier. So in blood brain barrier, endothelial secretes MAO enzymes, like monoamino oxidase enzymes. This endothelial enzymes contains metabolism, this endothelial cells metabolizes the drug. Okay. Placental barrier, placental barrier, which is small barrier when compared to blood brain barrier. Drugs can easily cross the lipids, like the drugs which are lipid soluble drugs can easily cross placental barrier. All things are being equal, we try with give a mom that water soluble or else highly plasma protein binding drugs. If it is water soluble, then obviously it cannot cross the placental barrier. If water soluble drugs are not feasible, then we would go for high plasma protein binding drugs. For example, in the case of in anticoagulation medication, we go for heparin, which is highly water soluble and large molecule and highest like high plasma protein binding. And in this slide you should know about ion trapping. What exactly? For example, opiates and local anesthetics are basic in nature. Normally fetus blood's pH is acidic when compared to mother's pH, uh, mother's blood's pH. See, fetal blood pH is 7.25, to 7.3. Mother's blood pH is 7.3 or 7.4, which is fetal blood is more acidic when compared to mom's. When you put a basic drug in acidic medium, it cannot be absorbed, it will be trapped. When you put acidic drug in basic medium, it cannot be absorbed, it can be trapped. Like weak bases are trapped in acidic medium, acidic drugs are trapped in basic medium. Why I am taking this example? See, opioids are easily cross the placental membrane when it reaches to fetus. Obviously in fetus it is more, blood is more acidic in nature when compared to mother. So it The opioid will be ionized and it cannot cross the membrane, and it would be trapped and it cause harm to the fetus. So never ever suggest opiates or local anesthetic in pregnant women. Which anticoagulant is safer during pregnancy? For example, like in heparin or warfarin. Heparin is highly prescribed. Why? It is the large as well as water soluble. Since it is water soluble, it cannot cross the membrane placental barrier, and it is also large. Large cannot be crossed by the placental membrane. So if you the answer, it would be heparin. Which thyroid agent is safer during pregnancy during first semester? Propylthiouracil or methimazole? Propyl uracil would be the answer, because it is having um, highest greater than 90% bound to the plasma proteins. More if the drug binds to more to the plasma protein, then there would be low volume of distribution. Higher the plasma protein binding, lower the volume of distribution. So propyl thiouracil would be the answer. If I ask you which thyroid agent safer during the pregnancy during second and third semester, then answer it would be methimazole. Methimazole would be the answer. Don't use propylthiouracil in second and third semester. It stays in mother's blood and it causes hepatotoxicity of the mother. Now let's discuss volume of distribution. What exactly it is? It uh, refers to space in your body to which drug appears to disseminate, like it appears to spread or disseminate. For in fixed principle concentration, it is, for example, concentration. What is exactly concentration? Concentration means how much grams in liter, like 3, let us consider 3 grams in liter. How much volume? Let's consider 4 liters. If I ask you what is the amount of sodium dash in like grams in the test tube, like amount, like volume is 4 liters and concentration is 3 grams, then it would be, answer would be 12 grams in this test tube. So amount is equal to volume into concentration. So concentration, what would be the what does it mean by concentration? Concentration, it would be amount divided by volume, amount grams by volume L. Cons a theoretical volume that relates to the dose of the drug given and the plasma concentration of the drug. See, the concentration, as we discussed earlier, concentration is equal to amount by volume. See, let's consider C naught is concentration and the amount is dose of the drugs, and volume is volume of distribution. If the high the volume of distribution, then concentration in the plasma. Concentration in where? Exactly where? In the plasma, in the systemic circulation, in the plasma. If the volume of distribution increases and the concentration of the drug in the plasma, obviously it decreases. If the volume of distribution is increases, then the dose of the drug would be increases. It is directly volume of distribution and dose of the drugs are directly proportional to each other, whereas volume of distribution as well as plasma concentration of the drug is inversely proportional. It is inversely proportional. Let's understand what exactly high volume of distribution, low volume of distribution, which drug is having high volume of distribution. For example, high VD, it means the drug is highly distributed tissues. What is high VD? For example, when you take a drug, it enters through when you take a drug through orally, it enters to stomach, from stomach intestine, from intestine through hepatic portal vein it reaches to liver, from liver through inferior vena cava it reaches to heart, from heart it distributes from the heart, from systemic circulation it distributes to the tissues. If the drug is high VD, means high volume of distribution, that then it means that drug is highly distributed, it won't stay in plasma, it distributes to the tissues. Low VD, what does it mean? It poorly distributed in tissues. What does it mean? It means that it would be stay in more likely in plasma than in tissues. For example, loop diuretic furosemide, it is having poorly distributed in tissues. Then what does it mean? The drug is mainly present in blood. See, lower the volume of distribution, higher the concentration of the drug present in plasma. See, see here, concentration of the drug in the plasma is more, then it would be lower VD, higher the drug present in plasma. This equation is very important with respect to GPAD. See, let's discuss causes and effects of VD. If increasing the plasma protein binding of the drug, then it would be decreasing VD, volume of distribution. If a drug that binds to the tissues more strong, see, plasma proteins like albumin, globulin, alpha acid glycoprotein, these are the plasma proteins. If a drug that binds to that plasma protein more strongly, then it would obviously doesn't go into the tissues. Furosemide is the example that it is strongly bind to the plasma proteins. Now let's consider tissue protein. If the drug is having more tissue protein binding, then it would be high VD. What does it mean? Like, if the drug is tissue protein binding, if the drug is having tissue protein binding is more, then it won't stay in plasma, it will be bind with tissues. The competition between two drugs for the protein binding also changes the volume of distribution. How, sir? Let's understand. For example, verapamil and quinidine. These two drugs displaces the drug. What is verapamil, sir? Verapamil is a and calcium channel blocker, and quinidine is antiarrhythmic agent. Digoxin is inotropic agent which is used in heart failure condition. See, free fraction of the drug moves from blood to tissues and tissues to the blood. Free fraction, which is active, free fraction or unbounded drug, both are same. They moves from blood to tissues, tissues to the blood. Both are in equilibrium in state. Like, if for example, consider if a drug uh, passes from tissues to the blood, it decreases the VD. See, verapamil and quinidine, they are displacing digoxin, which is already binded with tissue binding sites, like already binded with heart. If you administer, this is called drug-drug interactions. Drug interacted with another drug. For example, verapamil and quinidine are interacting with digoxin, thereby digoxin moves from tissues to the blood and it decreases the volume of distribution of digoxin. For example, Teja has cirrhosis now. What is the status of how increases VD or decreases VD? What would be the answer? Obviously, in cirrhosis condition, in liver failure condition, there would be less synthesis of plasma proteins, like albumin, alpha acid glycoprotein. Then there will be decrease of plasma protein binding of the drug. then increasing the fraction of the drug, like free fraction, unbounded of drug would be more. Then from the plasma or from the systemic serum, from the blood, it reaches to tissues very easily. Then it increases the volume of distribution. So these are the body compartment in which drugs may distribute in a 70 kg body weight. Drug characteristics, volume of distribution, compartment. Example: strongly plasma protein bound and extremely large drugs, 3 liters. For example, take a drug with 3 liters. Compartment: plasma. Example: heparin. Heparin, what is heparin? Anticoagulant, which is a strongly plasma protein bound and largely molecule, water soluble drug with low VD, 14 liters. It would be in extracellular fluid. Example: mannitol and gentamicin, small water soluble drug which is having 42 liters volume of distribution, like total body water. Example: ethanol. Drug with heavy tissue binding, like more tissue binding, like chloroquine. Chloroquine, where we use chloroquine like as an anti-malarial agent. It where it binds, if it is having more tissue binding, more volume of distribution, obviously it binds to in tissues and thereby increasing volume of distribution. Chloroquine having high volume of distribution in this when compared with these drugs. Hope you like this video. If you like this video, please do subscribe, hit that like button, share with your friends. Bye bye. Thank you for watching this video.